Good day. I want to thank Dr. Khurshid Mohammed for inviting me to present this, not only this presentation, but a series of presentations on neonatal neurology and with a mixture of neuroembryology and basic neuroscience that I think one needs to really understand what one observes clinically in the nursery. And so today's topic, I want to talk about initially about what is the neuroanatomical and neurophysiological basis of the various normal and abnormal postures that we see in preterm and term neonates. And then a little bit about the update of the Sarnat grading scale of neonatal encephalopathies. And a little taste of some basic neuroscience that I'll introduce also in a preliminary form. Thank you. And so I have no real disclosures, and I just want to mention that with the histological and neuropathological studies that human tissues are always treated with dignity and respect in our laboratory. And we are privileged to share the traditional territories of various First Nations who lived on this land before the European settlers arrived and continued to live here and are generous enough to share their lands with us. So the learning objectives in this presentation are, first of all, to understand the pathogenesis of muscle tone and postures and movements. And next, to understand the original grading scale and its application to perinatal hypoxic ischemic and other non-progressive encephalopathies, and then to appreciate some of the changes that have occurred since it was first introduced in 1976. And here are the references for both the original publication and the suggestions for some upgrades that was made more recently by my colleagues and me. First of all, I'd like to discuss muscle tone and postures. But beyond the description of the muscle postures, for example, we need to make correlations with clinical neurological signs with the pathophysiology and the neonatal neuroanatomy that produce such signs on physical examination, so that we can better understand why the postures occur and what we are seeing and how we can understand them in terms of involvement of the nervous system. There are numerous small tracts or pathways that descend from the brainstem to the spinal cord, bulbospinal pathways. And these are shown here in this slide here, listed some of them. And then there's the large corticospinal tract, which is not mature until 2 years of age, but still has functions in the term neonate and even in the preterm neonate, although those functions are somewhat different than in the adult. We can divide all of the descending pathways from the brain to the spinal cord into 3 groups: the lateral and medial subcorticospinal pathways, or bulbospinal pathways, and the corticospinal tract. And so to understand the effects of these pathways, and the investigators who originally described the grouping of these pathways from the brainstem were Lawrence and Kuipers, with their original work published in 1968. And they did this on the basis of studies experimentally in neonatal monkeys by stimulating and selectively destroying certain parts of the brainstem where the pathways originated to see what the effects were. And their conclusions were that the lateral subcorticospinal pathway causes some weak axial flexion, but doesn't affect distal joints. It's the least important of the three. The medial subcorticospinal pathway causes strong axial extension that would include the spine and distal and shoulder and hip girdles, and strong distal flexion, which would be the fingers, adduction of the thumbs, wrists, and ankles. The corticospinal tract causes just the opposite. It causes flexion of axial and proximal joints and distal extension. And so the important point to remember here is that the medial subcorticospinal and the corticospinal pathways are antagonistic to each other. So here we see on the left an infant 9 months of age who was born at term with acute asphyxia during delivery and is in a position that is called opistotonus. And opistotonus is strong extension of the vertebral column, as you see here with arching of the back and of the head. And you see the hips are in strong extension. And if you look closely at the hands, you'll see that there's a cotton wad that the nurse put in his hand so he won't damage his palms with his own fingernails because of the strong flexion. This same posture could be seen in a neonate, even though this baby is 9 months old. On the right is a different infant, a term neonate, who had something very similar, and this is to demonstrate the adduction of the thumb with flexion of the fingers and flexion of the wrist as well. And this is similar. What is the reason for that? The brainstem is more resistant to hypoxic ischemic injury than is the cerebral cortex. Therefore, the influence of the corticospinal tract from the cortex is going to be impaired sooner than or selectively more than the medial subcorticospinal pathway from the brainstem. And therefore, you're going to see the lack of this equilibrium or balance between those two antagonistic pathways, so that you see the result of the medial bulbospinal or subcorticospinal pathway uninhibited or unbalanced by the corticospinal tract. And that's how we can understand these postures. And this is just a summary of this antagonism that I mentioned. Here we have a premature infant, 30 weeks gestation, and this infant has the same thing. You notice the flexion of the hands and flexion of the toes as well. And the hips are not extended, however, they are abducted. Abduction and extension use the same pool of motor neurons in the spinal cord and neurologically are the same. And the reason the hips are abducted has more to do with the maturation of the anatomical structure of the hip joint itself, so that the least resistance would be with abduction in a 30-week preemie, whereas it would be extension in a 40-week term neonate. And so we should understand that this pairing. Similarly, adduction of the thumb and flexion of the fingers similarly come from the same pool of motor neurons and are the same neurologically. Even at present, there is continuing discovery and greater appreciation of the importance of the synaptic circuitry of brainstem structures and the bulbospinal pathway for postnatal motor control. And here's a recent article to document that. Now, another aspect that we see in the newborn, clinical aspect, is that between 26 and 32 weeks gestation, normal premature infants exhibit dystonic movements of the shoulders and hips and athetotic postures of distal joints of the fingers, wrists, and ankles. And this is a transitory physiological change that we see between these two ages. And this phenomenon was first described in 1961 by Professor Albrecht Piper, who was one of the earliest pediatric neurologists dedicated to neonates, neonatal neurologist. And he lived in Leipzig, which at that time was part of East Germany before Germany was reunified after the war. And his observations have been confirmed by many subsequent authors. And these figures that you see here of an infant, the hand and the foot, are original figures published in his book, published in 1961, which was translated to English in 1963. In addition to these observations in preterm infants, with real-time ultrasound, it's been demonstrated now that these same transitory dystonic movements also are observed prenatally. And they begin even earlier at about 15 weeks gestation. And this is a book by an Italian group that is very good in describing this. The infant illustrated on the book obviously is not a neonate, but it would occur in a fetus or a neonate. So these things, these dystonic movements and athetotic movements occur in utero, in the fetus, in amniotic fluid, as well as in the preterm neonate, who is that we see postnatally. So we should look for an explanation of the physiological dyskinesias in the premature infant. And the explanation might come from the sequence of synaptogenesis in the corpus striatum, which is the caudate nucleus and putamen. And as you can see in this study of ours, at 13 weeks gestation, there is no synapse formation within the corpus striatum. There's no brown staining that you see. At 21 weeks, what we see is a patchy pattern of synaptogenesis, even though histologically the neurons all look uniform and you don't see any differences. But with a synaptophysin stain, which is a glycoprotein that forms the part of that, it contributes to the synaptic vesicular membrane, regardless of the transmitter inside. We can see that there's this patchy network. And by 26 weeks, we still see this patchiness, but the areas that showed no synapse formation at 21 weeks now show some, but it's not as intense as in the patches. And by 40 weeks gestation, it's uniform throughout. That coarse white line you see at 40 weeks, that's the internal capsule, the anterior limb. And the smaller white circles that you see in the caudate nucleus and putamen are blood vessels. And so we have this transitory patchy pattern of synaptogenesis in the corpus striatum that does not occur in the globus pallidus. And there are only two places in the central nervous system, in the brain especially, where patchiness occurs in a normal physiological fashion. It does occur in some pathological conditions, in some malformations, but not normally. And the only other place is in the basis pontis, which is part of the cerebellar circuitry. So there could be, temporally, this coincides very well with what we observe in premature infants and in fetuses of corresponding age. And so, the explanation, excuse me, for this transitory dyskinesia may be the immature sequence of synaptogenesis that's occurring at that age. On the left in the screen is the table from our original paper from uh, on hypoxic, on neonatal encephalopathy. Actually, all of the babies that we studied in that paper was only a series of 21 initially, uh, were all had well-documented asphyxia in the perinatal period. And originally we had thought we would put that in the title, hypoxic ischemic encephalopathy, but decided in the end to call it simply neonatal encephalopathy because it may correspond as well to other types of non-progressive encephalopathies that occur in the newborn that are not primarily hypoxic ischemic in nature. And I think that was proved to be a wise choice. And this paper has had a lot of citation, probably because it was the first study of its type, and it was confirmed by many other observers and other centers subsequently who confirmed the results and therefore gave it validation. And on the right is a table that we are trying to make some more modern modifications of it. And so what has changed in these 48 years to suggest a need for update to the grading scale for neonatal encephalopathy? Well, in the first place, we have a lot more experience using the grading scale in multiple NICUs throughout the world. And there's consideration now of some clinical aspects that previously were given less attention, including neonatal olfactory reflexes and autonomic changes. The autonomic changes were described, but really weren't given much emphasis in the use of the grading scale, and I think should have more emphasis. There are advances in EEG technology, although EEG was supplementary and not a criterion of the clinical scale. And certainly neuroimaging has made many contributions now to understanding neonatal encephalopathies and didn't even exist in 1976. All we had at that time, besides plain skull rentgenograms, were angiograms and pneumoencephalograms, which were very invasive. Modern neuropathology also has advanced in these years, and now we have a lot of immunocytochemical reactivities that didn't exist in 1976 for studying patients' brains who do not survive despite the best of clinical care, to be able to demonstrate synapse formation, for example, as I just showed you, but many other features of neuronal maturation that are not seen with simple histological stains such as nematoxyl and niacin. And we now have a better understanding of the pathophysiology of abnormal posturing, dyskinesias, the generation of seizures, neonatal seizures, and correlation with developmental processes such as synaptogenesis. We also have new treatments. The main one right now that has contributed a lot is therapeutic hypothermia, but we also have new anti-seizure medications which are useful in the newborn, and there's other neuroprotective measures which are being developed. And so what are the changes proposed in the grading scale? Autonomic changes, I think, should be given more prominence to changes in heart rate, blood pressure, pupillary size, peristalsis, the GI tract, that can reflect vagal discharge or on the other hand, sympathetic discharge. and olfactory reflexes, which I'll describe. And we have now more EEG criteria, although they are not part of the clinical grading scale, which is strictly physical examination, neurological examination. And of course, we have the neuroimaging that we mentioned and some other special imaging features of ultrasonography of the brain. Transfontaneller ultrasonography has advanced greatly, and Doppler is very useful for showing cerebral blood flow velocity and resistance index. But again, these are not part of the clinical criteria, but are useful supplements. Now, I'd like to turn now to an aspect that was not previously considered, olfactory reflexes. The neonate shows constant responses to olfactory stimuli beginning at about 28 to 30 weeks gestation, really reliably from about, I would say, 30 weeks gestation. And the fetus also has been shown, again, with real-time ultrasonography, to respond to aromatic molecules that are dissolved in the amniotic fluid. And they get there through the maternal diet. If the mother is eating foods that have a strong odor, such as garlic, onion, certain spices, and curries, those molecules can pass transplacentally, enter the amniotic fluid, and be perceived by the fetus, and the fetus responds to them. And to test these in a newborn, we use an aromatic substance. You don't want to use something which is an irritant, such as ammonia, for example, or alcohol, because it will stimulate the pain endings of the trigeminal nerve, which also live in the nose, and that's a stronger response. And even though some of these substances, such as ammonia, have a very pungent and distinctive odor that wouldn't be confused with any other, you should avoid them because they stimulate the fifth nerve. We use peppermint, but you could also use a number of other substances which are aromatic to test. And the neonate should not be in deep, quiet sleep for this examination. He should be awake, or at least in transitional sleep. And sometimes you must repeat the stimulus several times during the examination to confirm your results. The responses you look for are that in about 2/3 of times, the infant will show a sucking response or extend the tongue or move the lips. And sucking is probably the most frequent. And in 1/3 of cases, there's a alerting reaction or retraction of the head or facial grimacing that also indicates that the child has perceived an olfactory stimulus. And in neonatal encephalopathies, including HIE, these responses may be diminished or abolished transiently. And so the absence of a response could be another criterion of the degree of encephalopathy. Let's see. And here you see a picture of a baby who is being tested. And I don't know how well you see this, but we're holding a small glass laboratory tube, which has a wad of cotton from a cotton ball in the tube with oil of peppermint oil on the cotton. And the baby responds to that. This is not a video. I can't show you the actual movements, but she did respond with labial movements. Cranial nerve 1 and the whole olfactory system is seldom examined in the newborn. Nevertheless, it conveys information about unique parts of the brain that are not tested by any other aspect of the neurological examination. And they may provide additional evidence to supplement what you already have. And here are some references to that examination. Now, to look at the EEG in the full-term neonate, it resembles the maturing EEG of the preterm neonate of 24 to 30 weeks gestation, because you see a semi-periodic pattern of bursts of activity, and then you have very low amplitude or almost flat activity in the interburst periods every few seconds. And this is a repetitious pattern. And so up above in A, you see a premature infant with the burst of activity. And in B, you see a full-term normal neonate in wakefulness. And you see that the activity in the brain is continuous, and you don't see these periodic bursts of activity. Here you have an EEG of a 3-day-old infant born at 29 weeks gestation who does not have encephalopathy. This is a normal pattern for this age, and you see the periodic bursts of high voltage sharp waves and slow waves that alternate with low voltage phases in between. And here's an EEG of a 3-day-old neonate born at term who has hypoxic ischemic encephalopathy. And you see there are semi-periodic bursts of activity and very low voltage activity in the burst in between. So why do you see this pattern? Well, again, if we look at synapse formation in the cortex, in the cortical plate at 19 weeks, mid-gestation, you really see no synapse formation yet within the cortex. Only a little bit of in the molecular layer of the Cajal-Retzius neurons would be the only activity that's seen. By 26 weeks, you see strong activity in the molecular layer, no synapse formation virtually in layer 2, and you have some synapse formation in the deep layers of the cortex. And these vertical lines that you see are thalamocortical projections to the cortex. By 33 weeks, we see synapse formation in all layers of cortex, but it's still the strongest, the greatest number of synapses are seen in the deep layer of the cortex and in the molecular zone. And by term, the synapse formation is fairly uniform throughout the cortex. So what's the reason for similar EEG in a normal preterm infant and a term neonate with hypoxic ischemic encephalopathy? Well, the EEG maturation in preterm infants correlates very well with synaptogenesis in the cortex in terms of time. In very preterm infants, there are too few synapses within the cortex to generate continuous rhythms. So you have this very low voltage, almost isoelectric activity, and the bursts of activity you see is only during active stimulation by the thalamic pacemaker, which discharges every few seconds and is actively stimulating the cortex from the thalamus. And that's what those bursts of activity are. It doesn't make any difference to the recording scalp electrode whether synapses have not yet formed, as in the preterm infant, or synapses are anatomically present, but they're non-functional because the hypoxia ischemia has caused the neurons to deplete the transmitter that they had and impairs their biosynthesis of new transmitter for a time, so that the synapses are non-functional because there's no transmitter there. And I think this explains why you see the similarity in those two conditions, one a physiological and one a pathological condition. Now, there are a lot of abrupt changes that occur at birth. There's expansion of the lungs for the pulmonary system, a lot of changes in the cardiovascular system, with pulmonary circulation opening up and the closure of the ductus arteriosus. In the GI tract, you get introduction of food, milk into the GI tract for the first time. And in the musculoskeletal system, there's extension of the extremities that's possible that were not possible in utero because the limbs were flexed during fetal life. The nervous system, however, doesn't show such abrupt changes during transition from prenatal to postnatal life, but is rather a continuation of developmental processes. However, there's new evidence that is showing that there are some changes that occur in the brainstem, at least at the time of birth, with the brainstem peptide system being activated by postnatal breathing, and that having effects on the nucleus solitarius and the pre-Botzinger complex, which regulates central respiratory rhythms. So that actually the old adage that there are no major changes in the nervous system by the occasion of birth is not entirely true, and we're just starting to understand what some of those differences are. We could ask whether hypoxic ischemic encephalopathy affects cerebral blood flow velocity and resistance index and the autoregulation of cerebral blood flow. And we can now measure these things with Doppler, especially living child. And the autoregulation of cerebral blood flow develops during the second half of the third trimester, develops very late in gestation. And so premature infants who are 30 weeks or 34 weeks gestation don't have autoregulation of cerebral blood flow. And that may be in part due to immaturity in the nervous system innervation, but it's also due to immaturity in the development of the smooth muscular sheath that's forming around blood vessels, especially intracerebral arterioles, which are the end organ of autonomic innervation. And so if the muscle isn't mature yet or isn't formed yet in those arterioles, then even if the nervous system is mature enough, the stimulation isn't translated into any change in blood vessel diameter because the end organ can't respond. And in a full-term infant, autoregulation of blood flow may be temporarily impaired. There are some new approaches to therapeutics, which I'm not going to spend a lot of time with. Therapeutic hypothermia is the best documented one and is the only really effective therapeutic intervention at this time to protect the brain from ongoing progressive damage. And it inhibits a lot of developmental processes or temporarily slows them down so that they don't become damaged. And there also are other approaches that listed here that may be useful. One of them is use of galectin, which has been shown to be very useful in adult stroke models, rodents, and also has been studied in neonatal hypoxic ischemic encephalopathy. And here's just a paper to demonstrate how this may work. Metformin, which has been used for decades in adults with type 2 diabetes mellitus, non-insulin dependent, to stabilize serum glucose, also, it turns out, may be useful in hypoxic ischemic encephalopathy, not so much to regulate glucose, serum glucose levels, but rather to attenuate white matter injury and the long-term effects of that in terms of cognitive impairment and other functions. And it's not recommended yet for routine use to recommend it to give to neonates, but it's something that's being investigated and something that may become an alternative treatment for those who are mildly impaired but not severe enough to require hypothermia. And then we have to ask the question as to whether the etiology of neonatal encephalopathy influence the outcome of treatment. Does it really matter whether the hypoxia ischemia comes from abruptio placentae, for example, or comes from a problem of arrested um, delivery or prolonged labor and fetal distress? And we've known for a long time that the length of the encephalopathy, beginning in fetal life before delivery, is one of the factors that influences the long-term outcome. But whether the etiology actually plays an important role is something which is being looked at more closely at the present time. I'm going to show that. Now, another aspect that is not widely known is that hypoxic ischemic encephalopathy may influence the axons which are still being projected, pathfinding, before they form their synapses at their targets. And there are many long and short axons that are still growing and in the process of developing at the time of birth, even full-term neonate. And synaptogenesis is far from complete in the term neonate. Corticospinal tract not until 2 years of age. Axons, the terminal point of the axon is called the axonal growth cone, which was named by Ramon Cajal, his first developmental neuropathologist. And he demonstrated that there are specialized endings of the axon seeking their target, and they form a continuously changing series of lamellopodia, which are sort of like veils in between the sharp filopodia, which are spikes, and the spikes are continuously retracting and new ones forming. So this is a very dynamic process. And the neurofilaments, the intermediate filaments and microtubules that are inside of the axon and of the growth cone have different shapes, so that in the filopodia, they're all in parallel, whereas in the veils of the lamellopodia, between the webs between the filopodia, they're randomly organized. And if there's something that attracts the axon to turn towards its target, they all become parallel. And so we see these ultrastructural changes as well. Now, if you take a neuron in tissue culture and you add calcium to the incubating solution, what happens is that you get collapse of the growth cone and retraction of the axon so that it actually shortens. This is the same cell before and after the calcium was added. So hypocalcemia and hypercalcemia in the preterm and term neonate can impair axonal growth and can delay synapse formation, since these can't reach their target to form synapses. Magnesium is another ion that should be considered. It's a calcium channel regulator. magnesium ion. But only 1% of the magnesium in the body is an ionized form as the metabolically active molecule, or ion, I should say. Magnesium sulfate, however, is frequently administered by obstetricians as an anti-seizure medication during pregnancy in women who either have a pre-pregnancy epilepsy or are suffering eclampsia. And I can appreciate that one wants to avoid many anticonvulsants which are teratogenic and may damage the fetus during development, especially early development, such as phenytoin and valproic acid, for example. And magnesium sulfate does act as an anticonvulsant. But excess magnesium can affect calcium metabolism and may result in retraction of growing axons in the fetus. So if the mother is being given magnesium sulfate to prevent seizures by the obstetrician, you should be aware that the infant may have some problem with axonal growth because of that after birth. Now, I'd like to give just very briefly, give you a little bit of basic neuroscience to show you some of the things that are being discovered now. Proteoglycans are polysaccharide protein conjugates, basically. And the most prevalent in the nervous system is one called keratan sulfate. And keratan sulfate is synthesized and secreted by astrocytes into the extracellular space. But one of the things it does is that in the forebrain, it forms in the extracellular space, it forms a kind of template of axonal fascicles. Here you see the internal capsule. On the left is the anterior limb, and the right is the posterior limb of mid-gestational neonates. And you can see that the internal capsule is formed by, the form is outlined by the keratan sulfate deposits. This is a template. It's a chemical template. And here you see the same thing in the internal capsule in a 9-week-old fetus and in a 12-week-old fetus. Why is this important? It's important because the first axons don't enter the internal capsule until about 14 weeks gestation. And so this template forms before the first axons actually even enter. So it does form a template that's preparing for axons to come, but not after the axons are already there. And in some malformations, such as holoprosencephaly, for example, not only are the fascicles formed, but the keratan sulfate seems to envelop each individual axon as well, which may affect its epileptogenesis, because it can stabilize the membrane then and prevent action potentials from being propagated and depolarization of the membrane. It's also very prominent in certain other structures in the brain. Here in a 26-week fetus, you can see the thalamus is very intensely reactive for keratan sulfate, and you can see it here in the astrocytes, higher magnification. And even earlier, here you have the globus pallidus that shows a lot of keratan sulfate in a 9-week fetus. The thalamus has not yet gotten the keratan sulfate, and that doesn't come until about 15 weeks. And so here we have a table of just some of the times when the keratan sulfate appears. And another feature of the keratan sulfate is that it covers the neuron. It adheres to neurons, but not to the dendritic spines. And the dendritic spines is where the axodendritic synapses form, and these are excitatory synapses. And keratan sulfate has a property of repelling glutamatergic axons and facilitating GABAergic ones. And so this explains really why the axodendritic synapses are excitatory, because they are glutamatergic, and the dendritic spines don't have the keratan sulfate adherent, whereas the axosomatic synapses are all inhibitory because they do have keratan sulfate, and they've repulsed any glutamatergic axons that try to form synapses there. There's also cross immunity with certain antibodies that other proteoglycans, such as chondroitin sulfate, that also are in the nervous system. And here you can see keratan sulfate in other tissues. On the left is a full-term infant showing the epiphyseal plate of the rib, and here you can see with hematoxylin and you can see that the chondroblasts in the epiphyseal plate are very intensely reactive. And in the vertebra, this is the vertebra of a 9-week fetus, the spinal cord doesn't show any keratan sulfate reactivity, but you see it strongly in this is all cartilage now. The vertebral body at 9 weeks is all cartilage. The first two ossification centers don't really appear until about 23, 24 weeks gestation. And so you see it in the arches and processes of the of the vertebrae. You see it in the vertebral body itself, and you see it as well in the notochord. And so the fact that these three parts of the vertebral body all come from different sources. The notochord and the vertebral body comes from paraxial mesoderm, and the arches and processes of the vertebrae come from neural crest. And so the fact that they are all reactive and shows that there must be a much earlier expression of this. And we see this in the segmentation of the neural tube, in which keratan sulfate contributes to a large measure to forming the septa between the segments or neuromeres of the neural tube. And we can see this also in the cerebellum. In the early cerebellum, there's a transitory septum on either side of the with keratan sulfate in the cerebellum that separates the vermis from the lateral hemispheres, which is not appreciated with the histological stains such as H&E. Even earlier, we can see this in gastrulation, and you can if you see carefully, this is the early embryo, and there's a black line that extends forward, and that's the primitive streak, and there's a little bit coarser white line on the other end, and that's the notochordal process, which is the predecessor of the notochord. It's not yet a rigid rod, and it has a lumen in the middle that the notochord doesn't have when it matures. But you can see here the reactivity in the notochord of a slightly of an older fetus, a 9-week fetus. Again, and the notochord secretes keratan sulfate because there are no astrocytes yet at this age. And so that was gastrulation. Gastrulation is important because it's when the three axes of the body and of the nervous system are formed, and it also first distinguishes neuroepithelium and as different from any other part of the developing embryo. So it's the birthday of the nervous system. And this is a famous quote from Lewis Wolpert, who's a famous British embryologist, that I find important. One other aspect of keratan sulfate is that 9% of children with Down syndrome have keratoconus, which is a corneal dystrophy that leads to progressive visual loss and blindness and is treatable. And the genetic form, the metabolic defect in keratoconus is a genetically mutated, truncated keratan sulfate molecular structure. And so if you have infants born with Down syndrome, they should be seen for the first year or so by an ophthalmologist to do a slit lamp examination and ensure that they're not developing keratoconus. So here are the conclusions that which we've already discussed, and I won't read these all to you. And I will close with one other quote from my favorite Roman emperor, Marcus Aurelius, who was a philosopher and was probably the only Roman emperor out of many who really had empathy and cared for his people and tried to improve the quality of life for Roman citizens and for people in other parts of the Roman Empire, as opposed to almost all of the rest of the Roman emperors who were narcissistic tyrants who only were interested in themselves. History has a way of repeating itself, doesn't it? Thank you for your attention.